Okay, so I think we'll get started. So dear participants, my name is Gab McDonough, and I'm the Educational Action Supporting Officer at ERN-EuroBloodNet, the European Reference Network for Rare Hematological Diseases. And it is my great pleasure to welcome you to the ERN-EuroBloodNet Thursday webinar. And the aim of these educational activities is promoting the interest on very innovative topics in order to stress among health professionals the cutting-edge advances in the field of rare hematological diseases. Webinars are mainly addressed on very rare diseases, complex disorders, and highly specialized procedures and implementation of guidelines. Before we start, let me share some home rules. Please note that the session is recorded and will be uploaded on our EBN e-learning environment. If you do not wish to appear, please turn your camera off and change your name on the platform. Also, please kindly be informed that your microphone is muted. If you have any questions about the presentation, please write them in the chat, and they will be addressed during the Q&A session at the end of the webinar. Today's webinar is on bone marrow failure genetic diagnostic by Dr. Flore de Fontbrune. Dr. Flore de Fontbrune has a current position in the Department of Adult Hematology Bone Marrow Transplant at the Aplastic Hospital Saint-Louis in Paris, France. After finishing her master's in science focused on cellular biology and her MD in clinical hematology, she had the opportunity to join the team of the adult hematology unit at the Aplastic Hôpital Necker Enfants Malades in Paris, France. And Dr. Flore de Fontbrune's focus and expertise is acquired and inherited bone marrow failure syndromes, acquired and inherited chronic neutropenias, and also stem cell transplants. So with that introduction, I hand you the floor. Thank you, Doctor, for joining us today. We're looking forward to your presentation, and it's all yours.
Thank you. Hello, everybody. Happy to take part of this program. Back to me, our European colleague that are in Paris for 1 week with EuroBloodNet to have experiment in bone marrow failure syndrome also. So it is the week of bone marrow failure under EuroBloodNet. Here are my disclosure, mainly related to PNH treatment. And I will, I have two chairs. You know that bone marrow failure are defined by peripheral cytopenia associated with decreased richness of bone marrow precursor, and according to the severity of aplastic anemia, the cutoff for richness is 30% of 50%. It is important to remember that the normal bone marrow richness depends on age, and usually in bone marrow failure, you can have remaining cells, mainly erythrocytes, more frequently than neutrophils or megakaryocytes that are frequently the less represent cells. You can have a small interstitial edema and relative excess of lymphocyte, mastocyte, and plasmocyte. Bone marrow cytology is also essential to exclude other diagnoses, and empty bone marrow is a rule, but in case of non-severe aplastic anemia, you can have normal or slightly decreased richness in the at the bone marrow aspiration. You can have moderate dyserythropoiesis, mainly in patients with Fanconi anemia and PNH, but it is also possible in other causes of bone marrow failure, and a relative excess of erythroblasts is also possible. You have to remember that this megakaryopoiesis or this granulopoiesis are not usual in acquired aplastic anemia, so it should induce more exam to exclude myelodysplastic syndrome or inherited bone marrow failure. Fibrosis is not usual if it is more than grade 1 fibrosis, and it also need to perform other analysis. So it is classical bone marrow failure histology with few residual cells and absence of major dysmyelopoiesis. Cytogenetic exam is also essential to perform a diagnosis of bone marrow failure. Failure of cytogenetic is common in about one case, 20% of the patient cells did not grow in culture, so you cannot perform cytogenetic. And in this case, you must perform exam by FISH to exclude bone cytogenetical abnormality. There are some cytogenetic abnormalities that are not that are possible in acquired aplastic anemia. It is a case of trisomy 8, del20q, or in elderly men, monosomy of the Y only chromosome, loss of the Y chromosome, and deletion trace 13q also. But there are other abnormalities that are not common in acquired aplastic anemia. It is the case of trisomy of the 1q chromosome or equivalent translocation that are more common in inherited bone marrow failure, especially Fanconi anemia and sometimes GATA2 or short telomere syndrome. The presence of this abnormality should induce to research inherited bone marrow failure. In the same way, monosomy of the chromosome 7 in a child with bone marrow failure should induce to look for some SAMD9 diagnosis or GATA2 diagnosis in older children, in adolescents especially. It is the two diagnostics you have to evoke in case of monosomy 7. And in adults, mainly myelodysplastic syndrome. In all cases of bone marrow failure, inherited or acquired, severe bone marrow failure require therapy, as well as moderate aplastic anemia requiring transfusion. Kamita score is used for acquired aplastic anemia, but the same level could be used for inherited bone marrow failure. In Europe, we have the habits to perform the same treatment for severe and moderate acquired bone marrow failure. And treatment depend mainly of the etiology and the availability of a match-related donor and the age. In case of moderate bone marrow failure, it is important to not delay the diagnosis exam because you have time, and so you won't have to make it in emergency when the patient will require the treatment. So moderate bone marrow failure and have to be explored. Notably because most of the inherited bone marrow failure will present as moderate aplastic anemia. A diagnosis of inherited bone marrow failure is possible with severe aplastic anemia, but it is less frequent. And you always have to look for a donor if the patient is young and will have an indication of transplant if you have a match donor. There is two big groups of bone marrow failure: acquired bone marrow failure, and acquired bone marrow failure are in their very, very, very large part immunological bone marrow failure. You can divide this in idiopathic aplastic anemia, post-hepatitis aplastic anemia associated with there is somebody up associated with PNH clone or pregnancy associated aplastic anemia, but all are immunological aplastic anemia. It is very, very rare to have toxic or drug-induced bone marrow failure. we see a lot of patients with bone marrow failure, and during the last 12 years, I think I have seen 2 patients with drug-induced bone marrow failure. So it's very rare, and most of the acquired bone marrow failure are immunological. The other group are inherited bone marrow failure, and the most frequent and the most typical is Fanconi anemia. But you will also encounter a lot of patients with short telomere syndrome. Other frequently diagnosed disease are megakaryocytosis. We will detail the form linked to THPO because it is important to know this disease. And more recently, diagnosed SAMD9 and SAMD9L and MECOM disease. No. I have 2 or the arc. Sorry. Up. But the spectrum of bone marrow failure is very large, as represented in this slide. You have a very, very large number of genetic disease that could present as bone marrow failure. For example, Schwarzman diamond, GETA2, it is rare, but it is possible. And it is not possible in each patient to make a full, quick evaluation of all the possible bone marrow failure. But it is very essential to perform a diagnosis between acquired and inherited, because in inherited form, you should not perform immunosuppressive therapy because it will not be efficient, and in most of the case, you will make the situation worse with immunodeficiency, increased need for platelet and red blood cell infusion, and increased risk of infection. In case of inherited bone marrow failure, there is a lot of forms in which you have to perform extrahematologic exam to diagnose other feature of the disease and to have special follow-up of this problem. In case of indication of allogeneic hematopoietic stem cell transplant, you have to choose the conditioning regimen and to adapt it to the disease, because some of these diseases required some specific conditioning, like Fanconi anemia or short telomere syndrome. And because you always have, in case of a familial donor, to eventually search if the donor could also be a carrier of the disease. There is a lot of situation where the disease is not apparent, and in mostly all inherited bone marrow failure, you will find a report in the literature where the donor was finally carrier of the disease. It is the case for GETA2, it is the case for short telomere syndrome. There is a lot of examples. So it is very important to have this possibility in mind. In some cases, you will prefer alternative therapy than hematopoietic stem cell transplant. It is the case for short telomere syndrome and Fanconi anemia with androgen. It is the case with ALTPO for patients with THPO mutation, and aspirin and or watch and wait in some cases. And moreover, you need to perform genetic counseling for related and for the patient if there is a risk of transmission to their childhood. In the opposite, in acquired bone marrow failure, in severe and very severe case, treatment is an emergency, and the time from diagnostic to start of immunosuppressive therapy and stem cell transplant is prognostic. So you don't want to lose time to perform exams that are not necessary. And it is important to try to identify the patients that require specific exam. So which test we have to do and for whom? The best tissue to perform genetical exam in bone marrow failure are non-hematopoietic cells, and fibroblasts are our preference because there is no risk of contamination by leukocyte. And if you are not sure of the pathogenicity of the variant, you can after perform functional testing. So, and it is the best way to confirm that the variant is present in all the cells, not only in the blood cell, and is not an acquired variant. Moreover, it could avoid, in case of mosaicism or somatic genetic rescue, some inherited variants that are not that you cannot see in the blood. But the problem is that fibroblasts require time to grow, and about 6 weeks, and this time will be more important with the time to perform genetic analysis. That's why we try to identify the patients that are really suspect of bone marrow failure. And we know that there is some very important clinical and biological exams that could help to identify this patient as risk of inherited bone marrow failure. The age at first symptom is very important. We know that in patients lower than, I write 10 years, but more 6 years, there is approximately a quarter of them that would have bone marrow failure, inherited bone marrow failure. And most of the patients with inherited disease are younger than 10 years at diagnosis. It is very important to look for family history, not only hematological family history, but also liver and pulmonary disease for short telomere syndrome, solid cancer, immunodeficiency, and also all cytopenia. Consanguinity is an important fact you have to look, and weight and size of the patient at birth and at the time of diagnosis could also help to perform a diagnosis. You have to look malformation, morphotype, K-FRL spot, other cutaneous abnormality, and also immunodeficiency manifestation like warts. Previous normal blood cell count is important because most of the inherited bone marrow failure won't have previous normal blood cell count. And the speed of onset, in some patients, they come to emergency and they have only thrombocytopenia, and 1 week later, they have all the lineage that are very, very low. And in this acute form, in most of the cases, nearly all cases, with one exception, it will be an acquired bone marrow failure. So the speed of onset is very important. There are some usual simple biological tests that could help also to classify the presence of an elevation of the fetal hemoglobin level before transfusion. That is a marker of inherited bone marrow failure when it is over 10%. Between 5 and 10%, it is more complicated. We have to adapt to the age also. The alpha-fetoprotein level, when it is elevated, it is highly evocating Fanconi anemia, and a PNH flow by flow cytometry that is also that is associated with acquired form, while it is not in all the cases true. After, you have specialized blood tests like telomere length measurement, chromosome breakage test, that are more specialized and will require more time to have the result. To summarize, patients with acquired disease are mostly patients over 10 years that have normal blood cell count in the 2 previous years, quick onset, post-hepatitis aplastic anemia also are typically acquired disease. and patient with PNH clone and telomere length over the 10th percentile. In the opposite, inherited bone marrow failure are young patients with abnormal blood cell count more than 2 years before, family history, consanguinity, clinical abnormality, and moderate bone marrow failure. And biologically, you will have elevation of hemoglobin fetal level, eventually Fanconi anemia alpha-fetoprotein, and short telomere, and some cytogenetic abnormality as previously detailed. PNH clone is tightly associated with immunological aplastic anemia. PNH is present in 40% of the patients with acquired aplastic anemia at all the levels, when you include all the clone, with new cytometry with Flore. And 20% of this patient will evolve to PNH, and in the other end, 20% of the patients with classical PNH will develop aplastic anemia. But in some very, very rare cases, you could have PNH in inherited disorder. We have a few patients with DDX41 mutation that have PNH clone, not large PNH clone, small PNH clone, 5% about, but it's not and we have the confirmation that they have inherited disorder. So it is an important point to orient your diagnosis, but it is not the case in all those. It is not formally excluding an inherited disorder, but it is chromosome breakage test. I won't detail, but typical chromosome breakage test with classical Fanconi anemia characteristic is the main diagnostic for Fanconi anemia. So it is very important to perform this exam when you have a doubt for Fanconi anemia. It is more important than genetic, because it is the main diagnosis to perform Fanconi, and the main test to perform Fanconi anemia diagnosis. And you have to perform Fanconi chromosome breakage test in all patients under 18 years, because Fanconi anemia is more frequent, and Fanconi anemia is not always associated with short stature, with clinical abnormality, and we'll all have a diagnosis of a patient that have not this abnormality and that was not expected to have Fanconi anemia by clinical exam. So all young patients should have chromosome breakage test, and eventually older patients that have clinical or biological abnormality that suggests this diagnosis. You also have to perform for young patients with myelodysplastic syndrome and clinical finding that suggest this diagnostic, because it is also a spectrum of disease that should suggest inherited disorder. And eventually at birth, if there is some classical malformation of Fanconi anemia, but also in older patients with non-expected head and neck squamous carcinoma. And more we diagnose also Fanconi anemia in patients with ovarian insufficiency, inexplained ovarian insufficiency and azoospermia, and we have some diagnosis, a typical diagnosis of Fanconi anemia in this context. So this abnormality should also suggest the diagnosis of Fanconi anemia. Leukocyte telomere length by Flore fish mainly is also an exam that could help to make a diagnostic of short telomere syndrome in a patient that is suspected to have short telomere syndrome, and to help you to decide to wait the result of a genetical exam before to treat your patient. But we know that in young patients with bone marrow failure, telomere length is also lower of the first percentile in comparison with the general population. But it is also the case of other bone marrow failure syndrome, especially other inherited bone marrow failure like Fanconi anemia that should have short telomere, or many all inherited bone marrow failure could be associated with short telomere, and also the case of some patients with acquired bone marrow failure. It has been demonstrated with post-hepatitis aplastic anemia, but we also have some patients with PNH-associated aplastic anemia and all kind of acquired aplastic anemia that have short telomere. So the presence of short telomere is not an equivalent of the diagnostic of short telomere syndrome, but in a setting, clinical setting that suggests short telomere syndrome, this is an important test to confirm. You have to wait the genetical diagnosis. I make an error because I think so. It's not very grave. I will share another. I make some change, but not in this version. I'm sorry.
No problem whatsoever.
Yes, I make some, yes, in my USB key. So it is not in the last version in my desk. So that is the algorithm we suggest to use for patient for clinical diagnosis in case of bone marrow failure. With all the elements we previously discussed, we prepare the patient over 18 years. If the patient have PNH clone or post-hepatitis aplastic anemia and classical screening, fetal hemoglobin level, alpha fetoproteins, and clinical exam and history is not suggestive of bone marrow failure, we won't perform other genetical exam. We consider that these patients have acquired aplastic anemia, and we will treat them according to their age, donor availability, with immunosuppressive therapy or bone marrow transplant. If the patient is over 18 years, but there is abnormality in this test that suggests inherited bone marrow failure, we will perform, according to the clinical exam and the test, chromosome breakage test, telomere length, and inherited bone marrow failure, NGS. And for all patients under 18 years, we will perform all these exams. If at the end with this test, chromosome breakage test and NGS, inherited bone marrow failure specific NGS, we won't have a diagnosis. It depends on the clinical and family history. If there is a very important arguments for inherited bone marrow failure, we will complete with an genome evaluation, because we have a national program for genome analysis with the parents in this case. If not, we will consider it is acquired bone marrow failure, and we will treat as an acquired bone marrow failure. But the most difficult is the time you have to decide if you will wait the exam before to start treatment or not. And in the case there is no problem, we will not wait. In the case there is a lot of evidence, and we will wait the result of the treatment, and before to to start any treatment, immunosuppressive therapy, or allogeneic stem cell transplant. And in the case that there are between these two situations, if the patient have no donor, we would start immunosuppressive therapy, perform the exam, and we will expect at 3 months, if the patient is not responding to immunosuppressive therapy, we will have all the results of the genetical exam if it is necessary to perform a transplant. And all these difficult cases are discussed with specialists, pediatricians, adult specialists in our national clinical meeting to help the referent physician to do the best choice. To detail the different, there are a lot, so I won't be able to detail all the form of bone marrow failure, but the most important, Fanconi anemia is very important because Fanconi anemia is linked to DNA repair deficiency, and it is one of the most frequent. Most of the Fanconi anemia genes are autosomal recessive, while there are a few FANC-B that is X-linked. The most frequent are FANC-A disease, FANC-C, and FANC-G. And in most of the cases, patient will have intrauterine growth retardation, small size, caféolate spot, clinical morphotype, and some malformation, mainly of the radial axis of the kidney and of the heart. Bone marrow failure usually present during infancy. The median age is 6 years, but it also could present in adults. And we have each year 1 or 2 diagnoses of Fanconi anemia in some adults, either with bone marrow failure or with myelodysplastic syndrome or AML, and also with unexpected head and neck squamous cell carcinoma. And as previously evocated, fertility is also a situation of diagnosis of Fanconi anemia. And the most important is that this patient have radio and chemo sensitivity, and we will require special conditioning regimen to avoid severe extra hematological toxicity and to adapt the follow-up, because almost all of the patients will have a cancer 10 to 20 years after transplant. We have a lot of patients we are following here, and with the evolution of the transplant in Fanconi anemia during the 30 last year, each month we have a diagnostic of cancer in a Fanconi anemia patient. So it is very important to keep it in mind and to explain it to the patient, because we have some patients that were transplanted in other centers that are not informed that they have a risk of solid cancer and that it requires a specialized follow-up with some stomatologists, with some gynecologists, because there is also a risk of genital cancer, and it's very, very important. And in this case, we know also that you can have somatic genetic rescue and mosaicism in brotherhood, so it is very important to look for the donor to avoid to have an affected donor. Short telomere syndrome is also an important diagnosis, and it is an under-diagnosed disease. At this time, we have more than 100 of patients of index cases diagnosed each year in France, either by hematological, pneumological, or hepatological first symptoms. It is a disease that is characterized by anticipation, which means that the next generation will be more severe and will have more early presentation, and that is clinically characterized by premature graying, abnormality of the pigmentation, ungual dysplasia and leukoplasia, but these symptoms, these manifestations are not present in a large part of the patient, are not evident. In hematology, you can have patients with only a mild thrombocytopenia or severe bone marrow failure or MDS and AML. But this patient, when you look very attentively, will have some mild pulmonary abnormality or liver abnormality, osteoporosis, avascular osteonecrosis, and we think that they also have an increased risk of B-cell non-Hodgkin lymphoma. In this patient, we know that we have to use the less toxic conditioning regimen because cells are not able to correctly repair also. And it's not reparation, but at the end, it is eventually the same. And a patient will have severe and hepatologic or pulmonary toxicity if you use busulfan-based conditioning regimen. So you have to use adapted conditioning regimen. And in case of bone marrow failure, the prognosis of transplant is not good in case of bone marrow failure, and moreover, in case of malignancy, where you have a high risk of relapse of the disease that are very high risk myeloid malignancy. So in this situation, we recommend to use in first line androgens that could induce response in about 60% of the patient before to discuss allogeneic hematopoietic stem cell transplant. You have to be very careful of the liver because androgen increase the risk of hepatocarcinoma, and we have an increased risk in short telomere syndrome patient. Another disease that you have to know is the SAMD9 and SAMD9L syndrome. This syndrome is characterized by bone marrow failure, associated in most of the case with over abnormality, especially neurological abnormality and endocrine abnormality, digestive abnormality. But it is not always the case, and we have some children with no apparent other disorder. It is usually young children, and usually when you look to the parents or the grandparents, you have a family history of transient cytopenia or bone marrow failure. And one of the characteristics of this disease is you have frequently monosomy 7 in the bone marrow, and this should suggest a diagnosis, because in this case, monosomy 7 is a somatic genetic rescue mechanism to delete the variant that is in the chromosome 7. So the somatic genetic rescue allow to eliminate the gain of function variant, it is gain of function variant, and to improve hematopoiesis. We can also find other somatic genetic rescue mechanisms, notably uniparental disomy or somatic acquired variant in SAMD9 or SAMD9L according to SAMD9, according to the genetical genes involved. And in this case, you can you may not see the inherited mutation in the blood because of somatic genetic rescue. So it is very important to look to the fibroblast, because in a lot of cases, we are not able to find the mutation in the blood. And in case of non-very severe bone marrow failure or high-risk clonal evolution, because clonal evolution is also a possibility, our strategy at this time, if there is no infection, very severe infection, or frequent need for transfusion, is to watch and wait, because monoglobin 7 is indicative of somatic genetic rescue, and most of this child will improve their blood cell count spontaneously. So we have a very close bone marrow and blood watch and wait strategy in this child, but in most of them we can wait. And it is also important to perform genetic counseling for the parents, and in case of pregnancy for the parents. So it is very important to know this disease and to search it when you have this presentation in children. Mecom syndrome is also a new bone marrow failure syndrome that is characteristic because it usually diagnosed before 12 months of age. So it is very young children. Usually the thrombocytopenia is a more severe lineage involvement, but you can have also classical severe bone marrow failure, and there is a frequent radiocubital synostosis that is that suggests the diagnostic, but you can have no malformation, or you can have other malformations, that earth malformation, deafness, and we know that this disease could evolve to myeloid malignancy, and that hematopoietic stem cell transplant in case of bone marrow failure is efficient. So it is important to recognize this syndrome. As almost all bone marrow failure syndrome, you can make diagnosis later. We have a patient that was diagnosed at 36 years old. And so while it is usually a diagnosis of infancy, you can make it later. THPO deficiency is also very important to know, because this patient present like other bone marrow failure syndrome, but usually in older children or adolescent, and with predominant thrombocytopenia like other megakaryocytosis. But they are less severe than MPO deficiency, and clinically they have no other classical abnormality. It is important to diagnose this patient because we know that hematopoietic stem cell transplant is not efficient, because it won't correct the THPO synthesis, and it won't correct the deficiency, and moreover, the stem cell won't engraft if there are no THPO in the blood. So we have performed some hematopoietic stem cell transplant, and we have it has confirmed that it is not efficient, and that the children finally died. So in the other hand, we know that L-thrombopag in this patient is efficient. So it is an easier treatment, and less toxic and more effective. Another rare but important disease that is not well known, that is Gozal syndrome, that is characterized by hematodiaphyseal dysplasia and bone marrow failure. In the last 5 years, we have performed 6 diagnoses of these syndromes in either infant or adults. And this syndrome is characterized by predominant anemia, usually with important red blood cell transfusion requirement, by bone pain, and mild inflammatory syndrome. And the characteristic of this patient is that the bone marrow is completely unaspirable. You can't have bone marrow cytology. It is not possible. You can't have karyotype, a cytogenetic exam, because you cannot have bone marrow aspiration. And when you perform a bone marrow biopsy, you will have an atypical bone marrow fibrosis. It's very atypical because there is a lot of edema, there is mild dysplasia, and there is decreased richness of the bone marrow. If you perform bone X-ray, you will have an increased density of the diaphysa, and these patients are sensitive to steroids. We know that they are sensitive to steroids from this disease was identified more than 50 years ago, but steroids are toxic, and it is not curative treatment. Each time to stop the steroid, each time the disease relapses. And recently, it has been published by other team and us that aspirin is very efficient in this patient. So when you have this diagnostic that is suspected, you perform a genetical research of TBX AS1 variant, and if you find it, you can give aspirin to your patient, and you will have full complete recovery in 1, 2, or 3 months. And it is very important because the clinical and hematological presentation is very characteristic. And also in this patient, we don't have, we don't know what will appear if you perform a transplant. We don't know that if the transplant will be efficient, or it is an inflammatory disease. So if you make the diagnosis, you will have a very simple treatment, no toxicity, and we will avoid other heavy treatment. Another important diagnosis to know in bone marrow failure is post-hepatitis aplastic anemia. It is a rare form. It is about 5% of all bone marrow failure syndrome in Europe, but it is mainly young children and adolescents, and mainly boys. And in this patient, bone marrow failure will appear 3 weeks to 3 months after a non-viral hepatitis. Usually, when patients have hepatitis, they have a complete blood count analysis, and at the time of the hepatitis beginning, it is normal. This hepatitis could be very heterogeneous in terms of severity. You have mild transient jaundice in patients that have not performed biochemical exam, and you can have fulminant hepatitis that required liver transplant in emergency. All is possible. But when you treat with steroid, usually the hepatitis is steroid sensitive, and also you can use anticalcineurin. When you look to the T-cell lymphocyte infiltrate in the liver, it is the same than you find in acquired aplastic anemia in the bone marrow. It is the same process. And for this patient, we know that treatment is the same than other acquired aplastic anemia. If you have to perform transplant, you have to perform transplant for the bone marrow disease. It is possible to perform a bone marrow transplant in a patient that has received a liver transplant if it is indicated. There is no contraindication. And if you have to perform immunosuppressive therapy with ATG and cyclosporine, you can do it. It will be efficient for aplastic anemia and for hepatitis. And if the history is typical, we do not perform any other exam. We don't wait to have a genetical exam. After, we have to perform other exams. Usually, we perform immunophenotyping of TB and NK cell at diagnosis, dosage of immunoglobulins, and autoimmunity marker. But we have to be cautious with the result. It is very important for parvovirus B19 because actually there is in France, I don't know in other country, but we have a lot of infection with parvovirus B19, especially in children. And we have a lot of patients that have positive PCR at diagnosis of aplastic anemia, and the treatment has been delayed because parvovirus was treated, and we wait the treatment with immunoglobulin, but in none of the case of severe aplastic anemia, we have seen an improvement after treatment of the virus, but it delayed the start of the treatment. So pancytopenia with parvovirus B19 infection is very rare and is restricted to patients with severe immunodeficiency, and you won't expect to have this in a patient without immunodeficiency. Another important question is there is a place for systematical somatic NGS screening at bone marrow failure diagnosis. It is very difficult because we know that somatic variants are very frequent in aplastic anemia at diagnosis and during the follow-up. And this somatic variant alone, if you have no cytological signs of dysplasia or no cytogenetical abnormality evocating MD syndrome, are not sufficient to change the treatment and to decide you are going to make an unrelated transplant in a patient who should receive immunosuppressive therapy. But we also know that there is more and more inherited genes in the somatic panels, and that sometimes you find an inherited disorder that you have not expected according to the clinical abnormality of the patient. But in general, we do not recommend to perform systematic NGS somatic screening at diagnosis of aplastic anemia in case there is no doubt with an hypoplastic myelodysplastic syndrome. Just very quickly, one story that is really informative, I think. It is a man we have seen a few years ago. It was a 22-year-old man. He was a resident. And in a systematical blood cell count, we identified a mild neutropenia and a thrombocytopenia. And when we looked to its past history, he already have thrombocytopenia at 12 years old. He had no other exam at this time, and when he experienced primary BV infection, he had a transitory important drop of neutrophils and platelets, and nothing was done. And after he continued to live with his thrombocytopenia. The familial history, there were mild thrombocytopenia in his grandfather and his mother, and other person have normal blood cell count. When he was explored, we see unusual dysgranulopoiesis in the bone marrow aspiration, and an abnormal cytogenetic with an equivalent of trisomy of the chromosome 1q. And according to these abnormalities that were not classical in acquired aplastic anemia, he was referred to a center. And the bone marrow biopsy also show only hypoplastic granulopoiesis. No, the other lineage were normal, while the overall richness was decreased. Clinically, this patient have no abnormality. He have a mild decrease in CD4 and B cell He have normal gamma globulin level, no PNH clone. Other parameters were normal, except telomere length that was slightly decreased. So they were short, not slightly short. And somatic NGS that has been performed was normal. So we perform inherited bone marrow failure test, NGS test in blood and fibroblasts, and we find an homozygous pathogenic variant of Schwarzman-Diamond syndrome. So the diagnosis in this patient that have no other clinical element for Schwarzman-Diamond syndrome was this unexpected diagnosis. And we know that all inherited bone marrow failure could have unusual presentation. And usually Schwarzman-Diamond syndrome patients have short size. They have pancreas insufficiency during the childhood. They have mild mental retardation. They have bone abnormality, and these patients are known of this problem. The other case I would like to present is this woman who was 99 years old. She had a history of thrombocytopenia that was treated by immunoglobulins, IRTPO, and rituximab from 1 year when she was addressed in hematology because the blood cell count dropped with anemia, neutropenia, and severe thrombocytopenia, and she had no response to the treatment. And she also had a diagnosis of steatosis related to overweight. And we were attentive to the fact that she had elevated fetal hemoglobin level. So before to decide to start immunosuppressive therapy, we decide to perform telomere length and genetical exam. And finally, this patient have short telomere and short telomere syndrome with an inherited mutation of TERK. And so we decide to treat her with danatrol, and she have complete response with the treatment and allow to progressively decrease the treatment. And actually, she keep a mild response, while a moderate response, while she had no treatment and no aggravation of the other liver or pulmonary disease. So it will have avoid to perform immunosuppressive therapy that should be a failure, that will not be efficient. And I will stop here. So for all this discussion, we have a meeting two times each month on the Wednesday, and all the physicians that want to present case in France, but also in other countries, could contact us if they are interested. Thank you.
Great, thank you very much for your presentation. And thank you for those that are at the preceptorship that are joining today. Perhaps, given the time, we can ask if there's 1 or 2 questions, depending on your availability. So just as a reminder, you can either add those questions in the chat or perhaps raise your hand. In the meantime, I just wanted to make a quick announcement about the next Thursday webinar, which I put in the chat here by Dr. Roberto Russo, which will be on October 24th at the same time, so starting at 5 p.m. And so, like I said before, now is a chance to ask any questions that you might have. Also, those attending behind you as well. But I imagine that this presentation is a preceptorship in itself. So thank you very much for your time and your expertise. And if there are no other questions or any other additional comments, I wish you a wonderful evening and hope to see you soon. Thank you all for joining.
Bye.
Thank you, Doctor.